So just a few minutes, but I hopefully have Reinhard on the wires across the big pond. Can I introduce him? A great colleague. He's working most closely really with Justin because there's been a lot of international collaboration so we can compare. It's one thing comparing what we do on the island, but there's another offering of comparing our standards and our performance with other people. And Justin and the NPDA team have been working for a long time actually with Reinhard, and he has a fantastic department where they're looking at the data and just drawing conclusion from the data. And I'm going to hand over to Reinhard, and the floor is yours, Reinhard. Lovely to see you. Over to you. Thank you so much.
Thanks a lot, Fiona, for the introduction. I hope you can hear me. I hope you can see my slides. I want to focus a little more on international collaboration. Justin already started that. I work in the south of Germany, University of Ulm. That's our university on the left. In the middle, that's the building I sit in and where my office is. And the building on the right, that's where I see patients with endocrine and diabetes problems. Okay, that's me. I'm a pediatric endocrinologist, and since around 1995, I coordinate this German, Austrian registry, and with respect to this talk, I have no conflict of interest. So quality improvement, kind of looking at a regional, at a national, at an international perspective, and some thoughts and examples on that. The first topic is, can we measure the quality of pediatric diabetes care? Well, NPDA and other groups have shown that at least in part we can measure that. Whether we can measure all psychological consequences, family interaction, that's maybe questionable, but we can measure metabolic control, we can measure short and long-term complications, and a lot of other aspects, and different registries differ in the exclusiveness and what they document or what they try to exclude. You just already discussed on time in range. Usually you need some demographics. You want to know about age and diabetes type and duration. Socioeconomic status, Justin referred to that, comorbidity. You want to make sure that in the end you have comparable groups of patients and that the conclusions you draw are actually valid. And then everybody focuses on metabolic control, HbA1c, you referred to time in range. We included time in range both as the CSV files of the glucose profiles as well as this aggregated time in range values, but also in Germany, 97% of our patients still have HbA1c values, maybe not as many as 5 years ago, but it's still the main measure of metabolic control. We look at acute complications, long-term complications, psychological complications, frequency, completeness of control exams, patient-reported outcomes. That's a topic everybody agrees that this is important, but it's not really easy to include that on a routine basis longitudinally in nearly all your patients. We have not yet managed that in Germany. Transition to adult care and continued documentation in the adult age is a topic. Looking at the cost of your service, that's also a topic. And there are many more topics, but then the slide was full. This idea to use data documentation, to use data analysis, to use continuous improvement process into medicine started kind of with the St. Vincent Declaration, late 1980s, early 90s. Methodology that was developed by Japanese car manufacturers take this into healthcare, and essentially this has proven to be successful in many parts of medicine, and we document and look at quality and outcome with slightly different terms, but we use this now in many areas of medicine. This St. Vincent Declaration, they developed a basic information sheet here covering important aspects, and then the pediatric group said we need also something for pediatrics, and there was a pediatric basic information sheet, and here you see some people who met and developed this: Christos Bartosokas, Knut Jorgensen, Henrik Mortensen, many years back in the 1990s. So once you have set up a standardized documentation, you can analyze your results. Of course, first you look at your service, at your pediatric diabetes unit, your institution. You can look longitudinally. Of course, you hope that this year you have better results than the year before and 2 years before. There may also be aspects that deteriorate, and you can think and discuss what's the reason behind that. And you can compare your results to current guidelines. If the guidelines say HbA1c should be less than 7%, you can look at the percentage of patients where you reach this cutoff and whether this percentage increases. You can relate your work, your workload, your outcome to the resources you have, personnel, doctors, nurses, money, and discuss this with your department head or clinic administration. You can also look at how you respond to acute challenges, and of course the COVID crisis was an acute challenge for many areas in medicine, and Justin already showed you an updated version of this. I found this completeness of exams. Everything was much worse during COVID. You improved rapidly. You see that eye exams are a major challenge. That's the same also in Germany and other services. I think it's a great idea just to drop the eye exams from the slide, then it looks much better. I will come back to the eyes later. Okay, from this look at your own service, you can look at a national or regional network. You have NPDA, we have this German, Austrian, Swiss, Luxembourg. We take the German-speaking, more or less German-speaking countries together, and every 6 months they get a report on how they are doing. I stay with the eye exams, and you see over the last 15 years, the blue line is the grand mean, all services taken together. And you see we are more or less stuck around 70%, and the last 5 to 10 years, no improvement. You see one individual clinic longitudinally. They always started an effort here, and then 4 years later again, and then they got much better, but afterwards they fell back. And in the lower part of this right graph, you see all our 317 pediatric diabetes units taken together. Each vertical line is one center. You see one center in the poor range, 33% of eye exams. That's really not good to talk about. We call the poor, the red range, less than 70%. See, 50% are there. You see average range, 70 to 90%, nearly half of our services are there. And about 10% achieve really good results, more than 90% with eye exams. We are really happy with that. That's the format we use for many of these quality indicators. We do it on these 4 nations together, but we do it also in an open format for regional quality circles. I work in the southern west, Baden-Württemberg. We have 33 pediatric diabetes centers. That's the region where we build the Mercedes cars and the Porsche cars. So we are very proud on how good we do. And you see, in terms of pediatric diabetes and eye exam, we have more or less the same distribution as in the same network. Few with more than 90%, majority 70 to 90%, many in the poor and red range. Yeah, so there's a lot of room for improvement. And these eye exams are complicated. We claim it on the eye doctors who are not willing to see our patients. So then it's not our fault. Now, moving from a regional view and a national or German-speaking view to a more international comparison, again, we can ask where are the strengths, where are the improvements, but where are challenges and limitations. And of course, this has advantages and disadvantages. The advantage is that you have a wider view beyond the boundaries of your national health service, which of course always interacts with the kind of care you can provide and the outcome. But you also have to deal with increased heterogeneity. Countries are different, and the more really worldwide comparisons you do, things may become also more complicated. You see, when you compare England to Germany, that's maybe possible, and both are rich countries and a lot of money in healthcare. When you compare England to Rwanda in Africa, of course, everything is different, and it has to do with economic resources, and it may be difficult to relate this to diabetes care. This international comparisons that kind of started with this video group, and you see here a table of happy people from around the world. Henrik Mortensen was kind of the leader of this group. They met in this nice building, and they also started with metabolic control, and you see HbA1c in Japan and England and the US and many countries. And they found, as everybody found, there are countries with good results, average results, and it's not countries, it's individual centers. That's important, centers with poor results, and they use these traffic lights as we do for good, average, and poor. If you want a more modern version of this, that's the SWEET initiative, a worldwide initiative to compare centers, and you have many centers from Europe, North America, Canada, but also South America, Africa. I think 23 centers from India, Australia, New Zealand, Far East, a really worldwide initiative. I aggravated the islands, as you probably say. You have England here, Ireland, North Ireland, no one from Scotland. I wonder why this is, but overall 7 from the islands. And there is room for more there. There are 138 centers who send data at least once, 120 who send data continuously, 100,000 pediatric patients. And looking again at this indicator retinopathy screen, annual screen, they report about 30% of patients that's poor. Biannual screen, more than 40–45%. 5-year screening, well, that's a long interval. They have a little more than 50%. So you see in this heterogeneous group of centers, results are on average poorer than what you reported for NPDA and what I reported for Germany. So the next step is to move from the comparison of individual centers to the comparison of more or less population-based groups, really comparison of nations, of regions. That's of course something to discuss when it's registry population-based, more than 90% coverage, more than 80% coverage. We have here registries with high coverage and lower coverage, T1D exchange and Australia. Yeah. Those international registries, they started to look at incidence and they try to understand this incidence trend. Why is type 1 diabetes getting more and more frequent? The idea to look at international differences and then get a clue on the reason behind that. After 40 years of this research, we more or less have to say that we are not more informed nowadays than we were 40 years ago. You know, this Eurodiap incidence registry collaboration, their most recent publication from last year, and they provide fantastic graphs with all participating regions, free from the UK. So you see, it's not the entire country, and they look at trends and gender differences and dynamics. It looks fantastic, but we still do not know what drives this increase. And somewhat more recently, maybe the last 10 years, those population-based registries also look at quality indicator. Here is a timeline of registries with this approach. You see NPDA starting in 2003. It's from a publication in 2022. Some registries started twice with an improved technology, and this is this publication, and you see countries who provide those more or less population-based representative data. As I said, for some countries there are some question marks. Yeah, looking at outcome, looking at HbA1c, that's an initiative driven by Scotland, John McKnight, Sarah, and they just compared median HbA1c about those regions. They were not too picky with the representativeness. You see, France is only Ardennes, and Italy is only Tuscany, and Australia is only Western Australia. Netherlands is only Rotterdam. But they took what they could get, and they see differences. And everybody was happy when they were on the left side, and less happy when they were on the right side. I also wanted to present this. Justin already showed you that, not just looking at the median, but also looking at the spread. And Germany, this blue line on the bottom, we have this huge spread between good and poor control patients, and it reflects our services, that we have many very small services with 20, with 30 patients, and you can, of course, select 20 extremely well-controlled patients, and then you are on the left side, and you can take care of 20 extremely chaotic patients who are not willing to travel 20 miles to a more specialized service, and then you get the respective result. Temporal changes. Justin already showed NPDA results, and putting this in a more international perspective, 3 registries who did a lot of those comparisons together. And NPDA, you see, you improved a lot. You improved most. You can really be proud, because in the same time, type 1 diabetes in the US deteriorated. Germany did not improve, but we were relatively stable, and it's more complicated to improve once you are already best. And nowadays, Scandinavian countries, especially Sweden, report better results. The dynamics among those registries, these groups also looked at the deterioration of metabolic control in puberty, and you see in all those countries HbA1c increases in puberty, and you see this increase is pretty much parallel, irrespective whether you are in Sweden, and perfect control in young children, they increase, or you are more on the upper side. This increase is pretty much the same. Another perspective, I think, may be important, of course, pediatric care ends. All our patients will switch to an adult service at some time point, but type 1 diabetes is a chronic disorder, and of course we want to put the basis for good metabolic control throughout the life, and a few complications throughout the life. So there are registries that include not only pediatric but also adult patients. Here you see 3 of them. You see type 1 diabetes, type 1 diabetes exchange, the US, that's the green one. You see Sweden, the yellow one, and you see Germany, Austria, the purple one, and you see 2 cross-sectional analyses, 2011 and 2017, and a lot of things changed. We see this pubertal increase, which is worse in the US, even got worse in 17 compared to 11. You see the improvement in Sweden, both in pediatric and adult. You see some improvement in Germany, Austria, more on the pediatric side. We are now the worst, report the worst data for younger adults with type 1 diabetes. So this lifetime perspective may also be important. Diabetes technology, nowadays everybody looks at technology. Again, Justin and Jennifer looking at technology use, pump use, sensor use, hybrid closed loop. As technology advances, you can always improve, repeat those analyses. My view is a little that we focus a little bit too much on HbA1c and on technology use. Justin already referred to socioeconomic status, and that's a comparison between the US on the right side, type 1D exchange, and Austria, Germany on the left side, two time intervals, 2012 or 11 and 17, light blue and dark blue. And here we have 5 quintiles of socioeconomic status. You see in Europe, in Germany, we also have slightly lesser pump use in a disadvantaged population and a slightly higher HbA1c. But this social divide is much larger, and in the 2 time interval, it deteriorated in the US. And from a pediatric view, where we think best care for all our children, yeah, this is at least an aspect we should look at. And then not to look at pump and HbA1c only, celiac disease, 3 continents, 4 registries, always with NPDA. You see the highest rate of type 1 patients with celiac in Australia. This goes along with population data on celiac antibodies in Australia, lowest rate in North America, 3% in both England, Wales, and Germany. And then looking at the DKA at onset. That's maybe not diabetes care, but of course it's also an important aspect to look at. And in this nice paper, Lancet Diabetes, a group of 13 international registries looking at the percentage of patients presenting with DKA, we see 10 years an increase in this rate. And this should really worry us. Medical care should improve, and pediatricians should improve, and lab work and all. But year by year, more children present in DKA. And in the 2 pandemic years, 2020 and 2021, we see even a jump up, and at least in Germany, 2022 and 2023, it did not come back to the previous trend. It's still higher than before. And here I really hope we can learn something from this international comparison. Why are we doing worse with the diagnosis of diabetes? So I hope I could present some aspects on a more national view on healthcare and outcome versus a more global view. Of course, we have to keep in mind that new medication, new technology, it's marketed on a worldwide basis. All the companies we deal with are internationally active companies, at least in those countries where the products can be bought, not too expensive. We look at international guidelines. We work with the same ISPED guidelines. We look at the same evidence base in the international literature. There is a lot of global exchange in research and healthcare. Healthcare professionals go to the UK because they earn more money, and we go to the same international meetings. There are initiatives to harmonize healthcare, but of course we also have to realize there are more views that we should come back to look at a more nation-centric picture and not care so much on the world, but look more on our nation only. This happens in a lot of countries. So I want to thank, of course, my team in Ulm. They do all the analysis. I hope you all listened and this was not all boring for you. And I want to spend our sponsors, and that's the end of my talk. Thank you.
Normally at this point you flip down your laptop, don't you? You walk away, but I can't do that. So